Welcome to the Fascia-Informed Therapist, the essential podcast for occupational therapy professionals looking to deepen their understanding of fascia's pivotal role in therapy and health. I'm your host, Amy Mayer, an experienced occupational therapist, practice owner, and dedicated educator. Here we'll dive into the fascinating world of fascia, exploring its significance in the human body and its critical influence on occupational therapy practice. Each episode will bring you cutting-edge insights, expert interviews, and practical strategies to help you confidently integrate the science of fascia into your therapeutic approach. Whether you're a seasoned practitioner or just starting out, our goal is to equip you with high-quality, evidence-based, and fascia-informed continuing education opportunities that will enhance your skills and benefit your clients. So join us as we unravel the complexities of fascia and transform the way you practice occupational therapy. All health and wellness practitioners are welcome. Let's learn, grow, and evolve together. Hi, this is Amy, and this is another edition of the Fascia-Informed Therapist. And today I'm recording down in my lovely writing retreat hosted by a friend of mine down in Green Valley, Arizona. And I am looking out into beautiful Arizona nature reserve outside my window. So this is a wonderful place to write. The book is coming along. Right now I'm working on the chapter that is dedicated to interventions that affect the fascial system. Today's episode is about myofascial pain syndrome, and this really makes me think about why I'm doing what I'm doing. And I want to reiterate, what is the fascia-informed therapist? I am a fascia-informed therapist, but I am not the fascia-informed therapist. I created the Fascia-Informed Therapist website, podcast, courses, because I think every practitioner out there in the field of occupational therapy, physical therapy, speech therapy, mental health practitioners, everybody out there needs to understand the science behind the fascial system so that we can better understand stuff like this, myofascial pain syndrome. It's becoming more and more common, and we need to know about it. We need to know how to treat it. We need to be innovating on how to treat it. And when you hear what's going on in this article, what they're saying about it, this is such an opportunity for occupational therapy to make a massive difference in these people's lives. So let's talk about it. Okay, so the article is a 2025 article called Myofascial Pain Syndrome, an update on clinical characteristics, idiopathogenesis, diagnosis, and treatment. And the authors are, I apologize if I don't get them quite right, Jeremy Steen, Kishore Jaswal, and Dinesh Kumbrahe. Now, this is a journal called Muscle and Nerve, and these authors are based out of Canada. So let's get into it. So as I said a couple times now, probably 2025 article. And I'm going to read chunks of it to you, and I will put the reference in the notes so that you can go find this if you want to. But here we go, okay? Myofascial pain syndrome is a recurrent chronic musculoskeletal condition characterized by localized pain and tenderness in specific regions of the muscle and fascia, often associated with presence of hyper-irritable nodules known as myofascial trigger points. These trigger points are localized hypersensitive nodules within the muscle tissue and are classified as either active or latent. So what is active and what is latent? Active means basically that the person can feel them all the time. They know they're there. Latent trigger points don't necessarily cause any awareness of pain, specifically at that site, until they are pressed on. Okay, these trigger points can cause loss of range of motion and muscle weakness, and as well as, of course, pain. They're saying in their introduction piece here that myofascial pain syndrome is often underdiagnosed or misdiagnosed due to an incomplete understanding of its nature and lack of internationally validated diagnostic criteria. They do talk about that in this article, so we will go into that. Okay, so let's talk about the prevalence. Estimates of the prevalence of myofascial pain syndrome vary widely due to differences in the diagnostic criteria. Nevertheless, the condition is recognized as a major cause of musculoskeletal pain across various populations among middle-aged adults. And they say middle-aged is 30 to 60, so I'm happy to hear that. I'm still middle-aged. The mean prevalence is reported up to 37% in men, and get this, 65% in women. And we know, hopefully you know from listening to past episodes, that Carla Stecco did her article on when estrogen goes down, pain goes up, the fibrosis in the fascia goes up, and pain goes up in women. So think about HRT, hormone replacement therapy. I'm not saying go do it, I'm saying go talk to your doctor about it, because the information and the understanding of that has changed massively in the last couple years. Okay, this is interesting too. Let's see, with especially estimates reaching up to 85% among adults over 65 years of age. And my assumption is, I'm going to throw in some of my assumptions and opinions, but remember, I have, gosh, what is it now, 34 years of clinical experience under my belt with fascia-related issues, so I think my opinions count for something. Okay, as we age, our activity levels typically go down, and I think that's also going to continue to get worse in today's modern culture because of more immobility in our younger and middle years, and then even more in our older years. So yes, we tend to slow down, but we don't, it's really a choice. Building in some sort of movement is so important for many reasons, and pain is most definitely one of them. Okay, another little piece of information in their prevalence section is in occupational settings, a study involving 243 female sewing machine operators, mean age 38 years, found a prevalence of myofascial pain syndrome of 15.2% in the neck and shoulders compared to 9% in the controls. Yeah, sewing machine. I don't know if you've probably sewing with a sewing machine is probably a dying art, I don't know, but I used to do a lot of that in my 20s and 30s. I loved quilting and sewing, and yes, it is really hard on the neck. You have to know how to take appropriate breaks and rests. Okay, more here. At one pain rehabilitation referral center, 85% of patients were diagnosed with myofascial pain syndrome. 85%. A pain treatment referral program known for its focus on myofascial pain syndrome reported 93% of individuals with musculoskeletal pain had trigger points, and in 74% of cases, the trigger points were considered the primary cause of pain. Okay, myofascial pain syndrome was detected in 61% of individuals with complex regional pain syndrome, and we know as occupational therapy practitioners that's a toughie to treat. One recent prospective cross-sectional study examined 224 previously diagnosed with non-specific neck pain and found 100% of them had myofascial trigger points. Among oncology populations, one study reported that 45% of breast cancer survivors developed myofascial pain syndrome 1 year after surgery, with active myofascial trigger points predominantly occurring in the shoulder girdle muscles. Another study found 11.9% of head and neck cancer patients developed myofascial pain syndrome following surgical intervention and radiation treatments. Okay, if you listened to the podcast a few ago, I don't remember how many ago, when I talked about the studies around post-breast cancer surgery, this fits with that. This fits with that. So we're starting to triangulate. And what we are seeing in the clinic in terms of so many women who are years post, and if you look on our Google reviews, you will see that in our breast and chest workshop, a woman posted that she had been having pain for years post breast cancer treatment, a mastectomy. She did not have reconstruction, and just coming to that workshop alone made a massive difference in her experience of pain that she thought she was going to have to live with the rest of her life. We need to know how to treat these problems. I know I'm probably very much speaking to the choir, but I'm hoping that maybe some of you out there will share this with your colleagues who are still resistant or still living in that place that fascia is something that we cannot affect. They're still in their minds. It's this hard stuff that they saw in their cadaver dissection labs, and it's not that. Okay, let's keep going. Okay, so this is interesting, and I think this is where occupational therapy comes in, but other disciplines can address these things as well. Myofascial pain syndrome is a multifactorial condition influenced by a range of intrinsic and extrinsic factors, which complicate both its diagnosis and management. And let me finish reading this, and then I'll go on my tangent. These risk factors can be broadly categorized into physical, systemic, psychological, and lifestyle-related factors, which may interact synergistically, further contributing to the onset and persistence of myofascial pain syndrome. Okay, so what I wanted to say there is this is where we shine as OTs, as OT practitioners, and also why we need referral sources as well. We refer a lot to mental health practitioners. We can address some of that as occupational therapy practitioners, absolutely, 100%. But sometimes the clients that I work with anyway, Caitlin and I, we're making a lot of referrals because there's history of trauma, or we work with so many people in their middle ages who are sandwiched in between maybe kids in college and aging parents who are ill. There's just so many factors that having a team that you could maybe not even a team, but people you know who you can refer to get people the help they need in terms of dealing with diagnoses like these. And then the other thing I wanted to point out here is the lifestyle related factors. It's how people use their bodies throughout the day that are one of the main lifestyle factors. And then you layer on top of that the whole other lifestyle factors, like, are they staying hydrated? What are they eating? How much inflammation do they have in their bodies? How much are they moving? What kinds of exercise are they doing? Is it linear? Is it non-linear? Are they doing things that are going to affect the health of the fascial system? Are they doing things that expand and contract their bodies, twisting their bodies, replicating the movements that we do in real life, but in perhaps a slightly more exaggerated way in order for our bodies to be able to do that when we need them to do that in real life? Okay, let's keep going. Small, medium-sized rant. over. Okay, muscle overuse is one of the most well-documented risk factors for myofascial pain syndrome, particularly in individuals whose occupations or lifestyles require repetitive or sustained muscle contractions. And that happens all over the place in people who are using computers and are typing, mousing, and they're sitting in a chair, or even I'm standing today. Not all day, but I'm standing right now. But if they're required, because I still hear from clients that they aren't allowed to get a standing station, and that's more common in office-based settings where they have like an open concept and they have these cubicles and everybody's sitting in a cubicle, but then if one person is standing, that just sort of, I guess, throws off the vibe, or then you can see into other people's cubicles, or I don't know exactly why they're being refused, but I have had more than one client who was refused a standing option because of that reason. And they're not expensive anymore, or you can makeshift one. I've got my tablet sitting up on a box so that I can record at the level that I need it to be since I'm standing today. Okay, so people, and it's not just about work, these constant muscle contractions are also crocheting and knitting, and activities like that became extremely popular over COVID, and my daughter being one of those people. And it's also something that's really, really good for other diagnoses too, to help you focus. It helps with anxiety, but some of these hobbies like that are also potential contributors. And a very, 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 very long time ago, I did an ergonomic evaluation when I was working at Creighton, and it was in the cardiac center, I recall, and they kept asking me to come back because this woman was having so many problems with her hands and arms. And she was saying it must be my ergonomics. And I'm like, her ergonomics look great. Her posture looks great. Everything looks great. And then I don't remember if it was the second or third time, I'm like, okay, let's start going through, what do you do at home? And she said, well, I've got all these grandchildren coming, and I don't remember if it was knitting or crocheting. I know there's a difference, and I get in trouble with my daughter when I use them interchangeably because I don't do either one. She was saying, I'm crocheting all these baby blankets, and I have to get them done because I've got 3 grandchildren coming in whatever month. And I'm like, oh, perhaps this is what's contributing to your hand and wrist and arm pain. So after a discussion around that, a discussion with her supervisor, we can't control what she does at home. Absolutely not. And you can't take away people's valued occupations, right? So what can we do? We can teach her how to better take care of herself. We can educate her that this is what's contributing to your problem. It may also be an overlay of the type of work that you do, but you're minimizing your risk factors with the work that you do. So let's minimize the risk factors at home as well. And then, of course, teach you how to do proper stretching and taking care of yourself so that you can get the things you want in your life done. And then you can also do your job with more comfort. Okay, another significant contributor to myofascial pain syndrome is postural imbalance, particularly when improper posture is sustained over long periods. For instance, forward head posture, commonly associated with prolonged computer use, can lead to increased stress on the cervical and shoulder muscles, promoting the development of myofascial trigger points. Okay, so this is something that I've been shouting about for quite a long time now on how, and people continue to clap back at me that posture is not important. It is. It is. Our bodies created, evolved, however you want to look at it, to function in a certain way and to function with massive variety. But if we continue to put our body in poor positions, our fascia will shape us this way. Our fascia will absolutely shape us that way. And then I do not like comparing the body to a machine, but we are biomechanically off then. If we are stuck in a rounded shoulder position with head forward, you cannot lift your arms up. If you straighten up, then your shoulder joint works better. It's as simple as that. But something else that I teach all my clients to, hope I get this number right, but when you have that head forward or that forward reaching posture all the time, you get that upper cross syndrome, right? You get the stuck in the front and they stuck in the back, but stuck short in the front, stuck long in the back. And hopefully you can, if you're just listening, I am recording this on video too. I don't think I said that at the intro, but when you get stuck long in the back and your shoulder blades and I believe it's 17 muscles are attached to each shoulder blade. When they are all stuck and layered together, you're getting so much buildup of tension, but also the fluids can't flow, the blood can't flow, the ground substance can't flow, the lymphatic system can't flow. So I teach them that if they want to reduce their pain and prevent it from coming back, because that is something they're also going to talk about here, is helping people figure out how to not just get rid of it, but prevent it from coming back. And again, where occupational therapy shines. So I teach them how to do shoulder range of motion exercises with a dowel stick or a yoga strap to start getting those muscles and fascia to glide across each other. Try to reduce the friction that's experienced back there. Try to create more openness so those trigger points don't form. We'll do another on exactly what is a trigger point and what makes it form. But for now, myofascial pain syndrome. Okay. Then they also talk about systemic metabolic conditions. And this is interesting too, and something that we can talk about with our clients and recommend to them. So we in some states, you do have to be very careful about nutrition advice, but we can absolutely ask them questions about their nutrition and recommend healthy diet in order to reduce inflammation. In the state of Nebraska, we cannot say this nutrition plan will help your diagnosis. That is a medical nutritionist, and that's a licensed profession in the state of Nebraska. So we can't do things like that, and that's probably true in other states as well. Okay, so systemic factors, including vitamin deficiencies and metabolic disorders, have been implicated in the development of myofascial pain syndrome. For example, vitamin D deficiency has emerged as a notable risk factor. A recent cross-sectional study found that approximately 1/3 of patients with myofascial pain syndrome had vitamin D deficiency. What low-hanging fruit that is in order to help somebody potentially improve their situation, their experience of pain. Similarly, hypothyroidism is associated with generalized muscle weakness and fatigue, which predisposes individuals to the development of myofascial trigger points, reducing the muscle's ability to recover from everyday stress. Now, they don't even get into anything like diaphragmatic breathing in here, which is also low-hanging fruit. Okay, here's another one. Iron deficiency, particularly in premenopausal women, has been linked to increased muscle fatigue and reduced muscle oxygenation, both which can contribute to myofascial trigger point formation. So a couple pretty simple things that we can say, hey, why don't you go get your D levels or your iron levels checked? And that's something people can even do nowadays by just going to a lab and getting their own blood drawn. They don't even have to go through their primary physician anymore. Okay, the next section they talk about is psychological and emotional factors. Psychological stress plays a central role in the development and exacerbation of myofascial pain syndrome. Sorry, my voice is going a little, it's so, I love it down here, but it's so dry. It's so dry. I'm going to take a sip. Okay, chronic stress, anxiety, and tension can lead to prolonged muscle contraction, particularly in areas like the neck, shoulders, and jaw. The sustained muscle activation can create a cycle of pain and dysfunction, as myofascial trigger points are more likely to form in the muscles that are constantly under tension. We also know from past podcasts and other things that I've talked about that people with depression, anxiety tend to keep their shoulders up higher and tension in their shoulders and have more fibrosis and thickness in the fascia around their shoulders and upper trapezius, so neck and shoulders. Depression has been linked to higher prevalence of myofascial pain syndrome, with chronic pain patients often exhibiting depressive symptoms that can exacerbate this condition. And this is an important piece too. The relationship between depression and myofascial pain syndrome may be bidirectional. And this is what Lisa and I talk about in our workshop, where we're talking about emotional pain and fascia. Individuals suffering from chronic pain are more likely to develop depressive symptoms, while depression can heighten the perception of pain. Goes both ways. Sometimes the depression comes because you have so much pain, but the depression comes first. That can create the pain. And a lot of people aren't aware of that. So again, sometimes just helping people understand where everything's kind of potentially coming from. We're not doctors. We're not, well, I am a doctor, but I am not a medical doctor. So we cannot do the diagnosis, but we can certainly give people information that they can take back to their practitioner. And I think more and more physicians, oh, that was a very pretty bird, bright yellow bird out there. There's so many birds here because they live really close to Madera Canyon, which is known for its tremendous variety of birds. Anyway, and Linda put a nice little bird feeder right outside the window for me. So yeah. Last time I was here, I also saw a bobcat outside the window and various other little critters running around. Anyway, okay, so the next section that they talk about is lifestyle and behavioral factors. Sedentary lifestyle significantly increases the risk of myofascial pain syndrome, as prolonged inactivity contributes to muscle stiffness and reduced flexibility. Individuals who do not engage in regular physical activity are more prone to muscle deconditioning, which can exacerbate the trigger point formation and prolonged duration of symptoms. Regular exercise, on the other hand, helps maintain muscle health by improving flexibility, strength, and endurance, and reduce the likelihood of myofascial pain syndrome. They also talk about this in relationship to the jaw and TMD. They talk about sleep disturbances and insomnia, another critical risk factor which is something we also address as occupational therapy practitioners. Okay. All right, hypothetical pathogenic mechanisms. I'm going to breeze through this section a little bit because most of the people likely listening are wanting to get to the more hands-on pieces of this. But the pathophysiology of myofascial pain syndrome is complex and not yet fully understood. There's several hypotheses, theories, and mechanisms have been proposed to explain the development of myofascial trigger points. The proposed mechanisms describe both peripheral and central effects on the observed in myofascial pain syndrome. The concept of pain originating from the muscle and/or fascia felt locally and at distance site, or referred pain, was first introduced by Kellgren and later expanded upon by Hockaday and Whitty and Mentz. So one of them that they talk about is called the Cinderella hypothesis. I thought this one was interesting. They're basically saying here that the smaller, let me just read it. Smaller type 1 muscle fibers are activated before larger ones and are deactivated after them. Consequently, these smaller muscle fibers are continuously engaged during prolonged motor tasks. So they're basically saying that the small muscle fibers are continuously turned on. And if they're continuously turned on, then there's a constant clenching, which is going to likely trigger the fascia to tighten up as well, because the fascia responds to mechanical input as to what we're asking it to do and how to form itself. So now, it also should note that the body isn't ever completely fully relaxed and just floppy, or we'd kind of just turn into a flat pile of mush of bones, I guess, and other organs and tissues. But they're saying that when we prolong activation, which is likely due to these jobs where we're moving a lot or we're holding our muscles tight in certain positions to type or mouse, or when we're tension and clenching due to tension and maybe trauma and stress, that those tissues those fibers are continually being turned on. And they're talking about it as a Cinderella hypothesis because the other tissues get to rest and relax while these smaller ones do all the work. So they're likening it to the Disney movie, or the story, not the did, started with the story before Disney came along, the Cinderella story. There's the neuromuscular junction dysfunction, the presence of dysfunctional end motor plates, integrated trigger point hypothesis. Let me see if I can find proposes a similar explanation for pathophysiology. According to this hypothesis, repetitive microtrauma to muscle fibers leads to excessive release of acetylcholine and increased end motor plate activity. Then they also talk about central sensitization. This refers to heightened responsiveness of neurons in the central nervous system. Neurogenic inflammation is proposed, another potential cause of this. And then the last section, they talk about densification of fascia. And the idea of fascia, I think, is much more, the modern understanding of fascia is much more common, I think, in Canada than it is here in the United States. Another proposed mechanism in pathophysiology of myofascial pain syndrome involves the pathological changes in the muscular fascia, the connective tissue that surrounds the muscles. Stecco, who I bring up a lot, suggests that under conditions of overload and damage, the fascia can undergo densifications, leading to alteration in the biomechanical properties of muscle tissue. These alterations in the muscular fascia are thought to be associated with abnormal changes in myofibrils, fibroblasts, and the extracellular matrix. So the current method of diagnosis remains challenging due to the absence of widely accepted objective and standardized criteria. It's typically based on subjective clinical criteria, including patient-reported pain and the exclusion of other pathologies and the clinical palpation of myofascial trigger points. And there's quite a few that here's what I was looking for. Okay, so they are developing imaging techniques, including magnetic resonance imaging, elastography, ultrasound, and infrared thermal imaging. They're being explored to visualize structural and functional changes in the muscle tissue and assess blood flow and stiffness differences associated with myofascial pain syndrome. They're also looking at vibration as a potential way of better understanding this diagnosis and diagnosing it. They also talk in this article about differential diagnoses, trying to understand the difference between myofascial pain syndrome and fibromyalgia. And basically what they say in this article is that in myofascial pain syndrome, there's more localized points of pain that when you press on them, they create this familiar experience of pain. Where fibromyalgia is more a systemic, body-wide, and don't show as many of these very specific trigger points, for example. Let's see, they compare myofascial pain syndrome to joint disorders, and they talk about how it's more localized within the muscles rather than specific to the joints. Okay, then let's get into treatment. I'll just kind of address some broad categories here. The first broad category is pharmacological treatments, and they talk about the effectiveness of muscle relaxants. I'm kind of scrolling through here too. They do list several types of muscle relaxants. And if you want to know what they are, let's see. Cyclobenzaprine, tizanidine, baclofen. And then the next broad category they talk about is antidepressants. One RCT, randomized clinical trial, reported significant improvements in myofascial tenderness and headache intensity with amitriptyline compared to a placebo in patients with chronic tension type headaches. Another clinical trial on myofascial pain syndrome and TMJD found significant pain reductions at 6 weeks and 1 year with amitriptyline use. Okay. The next broad category they talk about is analgesics, and that people can get some relief from analgesics. And they list several different kinds. The next they talk about is needling therapies, but trigger point injections. Let's see, local anesthetic injections alleviate pain by binding to sodium channels. Let's see, here we go. LA injections have consistently provided short-term pain reduction compared to DN. What is DN? In systematic reviews and meta-analysis on the neck, head, and shoulders. However, these benefits were less pronounced in double-blind studies and did not extend to functional outcomes such as cervical mobility or psychological factors. They talk about a couple different kinds of those types of injections, and then the next category they talk about are needling therapies that are non-pharmacological, such as dry needling. Several systematic reviews and meta-analysis have assessed the effectiveness, DN, dry needling, compared to sham or placebo in patients with myofascial pain syndrome. Most studies suggest that dry needling provides significant short-term pain relief over sham. A systematic review on upper quarter myofascial pain syndrome and dry needling significantly reduced pain immediately after treatment and at 4 weeks post-intervention compared to sham or placebo. Now, that's great, but I know a lot of people who do not want needles, even the teeny tiny ones that they use. Okay, and then they talk about acupuncture separately from dry needling. A systematic review and meta-analysis on lumbar myofascial pain syndrome found that acupuncture was more effective than NSAIDs, lidocaine, and low-frequency E-stim for pain relief. Similarly, 2 systematic reviews on the head, neck, or back myofascial pain syndrome reported significant improvements in pain, with one review noting that benefits were observed only when acupuncture was applied directly to the trigger points as opposed to the traditional Chinese medicine points. which I think that is really interesting, and that sort of makes it more like dry needling. I don't know a ton about either one of those, but. And then the next category is non-pharmacological treatments. So the first one they talk about is TENS, transcutaneous electrical nerve stimulation, systematic review on TENS for myofascial pain affecting the trapezius muscle reported significant improvements in pain, neck, range of motion, and PPTs. What is the PPT? I have to go back and find that acronym. It'll probably come to me at some point. Okay, then they talk about magnetic stimulation, ultrasound therapy, laser therapy, extracorporeal shockwave therapy. I know that's becoming more popular. I've had clients ask me about that more. A systemic review and meta-analysis on MPS, myofascial pain syndrome, found that ESWT, the extracorporeal shockwave therapy, significantly improved pain and functional outcomes compared to sham. However, did not show significant advantages over other treatments such as dry needling, exercise, TPIs, or laser therapies. And then finally, we get to manual therapy. A network of meta-analysis comparing various manual therapy techniques for myofascial pain syndrome found that combined interventions achieve the largest effect size for reducing pain intensity, while afferent reduction techniques had the greatest effect. Additionally, a systematic review and meta-analysis reported significant improvements in range of motion with manual therapy interventions, and another identified immediate short-term benefits for both pain and range of motion, specifically using ischemic compression for MPS. Then they talk about kinesiotaping, and then they get to their conclusions. And this is already 40 minutes long, so that's probably good. So their conclusions are basically requires a multimodal approach and integrates pharmacological and non-pharmacological therapies. And I think that's true. There isn't a one thing that we do there are one things that we can do that make a huge difference for people. And I find that myofascial release often helps to break the pain cycle. And it feels good. It helps people take that pain level down so that they can start moving better. And when they start moving better, that's what's going to really help sort of clean up that experience of pain or really get rid of that. And then that's also what's going to help that from coming back, their pain from coming back. The movement, the posture, the managing the stress. So they're saying it's got to be multimodal. And if they're saying pharmacological input helps, great, I'm sure that it does, but there are more and more people who are wanting to avoid that for multiple reasons. Things like side effects, or they did talk about opioids in here a little bit, potential addiction issues. More and more people are kind of afraid of and wanting to stay away from the pharmacological therapies. It's not going to be everybody. Sometimes I'm like, where's my ibuprofen? But most of the time, I'm going to close to 100% of the time, I'm going to try something else first. Evidence indicates sufficient support for the use of local anesthetic injections, which consistently demonstrate significant improvements in pain and functionality compared to placebo and alternative therapies. Some evidence supports the use of dry needling, acupuncture, magnetic stimulation, ultrasound, laser therapy, and manual therapy for improving pain, range of motion, particularly when compared to sham or placebo. However, their effectiveness relative to alternative therapies remains inconsistent. So what I've found is when people go for things like the injections or the medications, then those practitioners aren't talking to them about the movement and the posture and the stress management. For instance, one of my clients just sent me what do you know about this? And this was where they were injecting saline solution into the fascia around a nerve in order to expand the fascia and take pressure off the nerve. And I can't remember what it's called right now. And I had never heard of it and started digging into it a little bit more. And even on their website, they say, you're going to have to keep coming back and getting this over. This will last you, I don't remember how long they said it would last, probably different for everybody. But there was nothing in there about why did this happen in the first place? Can we identify anything in your lifestyle in terms of your movement or lack of it, how you move, how you hold your body? Those types of practitioners aren't doing that. That is what OTs are particularly good at, and some physical therapy practitioners as well. So if you are sent someone, well, let me put it this way. You might be sent a client that has maybe wrist pain, or maybe they had a stroke, or maybe whatever setting you're in. But as prevalent as myofascial pain syndrome is becoming, if it's not the primary diagnosis that's being referred to you, it's potentially a secondary diagnosis that this person has relative to what you're seeing them for. So having some knowledge about it is, I think, going to be very helpful as it continues to expand. Hopefully at some point we'll reach that tipping point and it will come back down again because more people will be aware of the diagnosis and what it takes to prevent it from happening in the first place. And then if they do get diagnosed, what can they do to make sure it doesn't come back? Okay, that was a long one. Again, I hope that you will get educated about fascia science, take our anatomy course and learn exactly what I believe is the most helpful to me in my understanding of fascia science. It's not too much and it's not too little. I think it's just the right amount that OTs need. So, and then if you want to learn about posture, because I think that's a really important piece of this as well, we have a really great posture course for practitioners as well. And movement. I think it's all important, and thank you again for listening. I hope this was helpful, and I'll put the citation in the notes. Everybody have a great day. Thank you for tuning in to the Fascia-Informed Therapist. It's been a pleasure sharing insights and strategies to help you integrate fascia science into your practice. I'm Amy Mayer, and I hope today's episode has inspired you to explore further and take your therapeutic skills to the next level. Remember, we're committed to creating and providing top-notch, evidence-based, fascia-informed continuing education that empowers you as an occupational therapy practitioner. Stay connected with us for more enriching content, and don't forget to check out our online courses to deepen your expertise. Until next time, keep expanding your knowledge, refining your skills, and confidently applying the science of fascia to your practice. Here's to advancing together in health and wellness.